washed my hands, enter the room. We need to assess our patient whether or not they need suctioned and if we need trach care or not. You may not see an order for trach care on the chart because that is considered routine maintenance. However, you'll have a protocol on what you can and cannot do. You never should put anything that's like petroleum products near the incision of the trach. And you're only going to use any kind of antibiotic ointments or creams at a physician's order or per your protocol at your facility. You also want to make sure that all of your equipment is working, and if you have a patient who has a trach, that patient needs to always have their call light or a bed alarm, a mechanism for which to reach the nurse at all times. For them not to have that could compromise your license, and you can have your license suspended and taken away. You also need to have working suction, and that can be a head wall unit, or like in our example, we have the bedside table. So you want to make sure that that is working, and I'm going to ask one of the students to turn that on so that we know that it is. So you want to test that equipment. Usually they will have your suction hooked up. It will be capped to maintain a clean system, and or a Yonker suction if your patient has a lot of oral secretions. We don't have the cap, which often you're not going to have. So what you can do is take and cover with some type of a cap off the system, or you'll have like the Yonker cover or something like that. So I'm just going to put that, and they'll have that tucked up at the end of the bed, which is considered the clean end of the bed. I'm now going to take my stethoscope. You're going to assess for the need, so we're going to listen to breath sounds. Some of your patients are going to be indicated that that they need to. Others are going to be compromised and not able to tell you what they want to do, that they need it. So it's up to you to fully assess. We're going to put a pulse oximeter on our patient and do a complete set of vital signs. You don't have to do temperature necessarily, but if it's time for their vitals, you might as well just get them all. So we're going to do a pulse oximeter at the same time and watch the patient's oxygen status. I'm also going to get their pulse. Blood pressure, depending on the status of your patient. You might want that. One of the complications of suctioning and trach care is that you can cause a vagal stimulation and cause the heart rate to drop and the blood pressure to drop. So you kind of want to know where you're standing on that. We're going to, if your patient is on oxygen, you want to hyperventilate or hyperoxygenate them. If they're on a ventilator, sometimes you give them, there's some buttons you push that cause them to take a series of deeper breaths prior to the suctioning, or go through what's called a sigh. And again, this just makes them take in a deeper breath and hyperoxygenate in the meantime. So if your patient is getting oxygen, I would recommend a second person to assist you. If you're not used to doing trach care, a lot of times you're going to be by yourself, so I would recommend that you practice as if you're by yourself, but also practice with somebody that, and you tell them what you need them to do. Okay? There's a lot of different ties that can be used on the trachs. This particular patient has the cotton tie that comes in the kits. You're not going to see these used much clinically. You'll probably see these used out more in the homes during home care. Again, any additional equipment we use is of additional expenses. So there are some Velcro ties, and those are really nice because they don't put pressure on the skin. You have less breakdown. The Velcro is easy to get on and off, so it makes it nice. This particular patient has in a trach that has an inner cannula. There's two different types of trachs. There's non-fenestrated and fenestrated. A non-fenestrated trach does not have holes in it. This won't be used for a weaning process. A fenestrated trach, the primary cannula that is attached to the appliance or that face plate has a hole in it that would allow when, if we were to put a button and all on, it will allow the patient to talk or to, again, breathe in a regular manner. When a patient has a trach, they're not using their nose and mouth for breathing. This bypasses the mouth and nose. So this is their airway. It's their only airway. So you want to make sure nothing ever covers or gets on top of that. Okay. I suggest, again, after you've hyperventilated the patient, you're going to talk and explain to them what you're doing. If they have on a patient gown, these two ties look very similar. So I was taught to make sure that I put the gown down and put those ties away. And I would caution to always make sure that you understand when you untie anything on the trach, if you have these cotton ties, to make sure you're not getting a gown. There have been incidences where this gets untied and patients' airways come out during the procedures or after the nurses left the room because they inadvertently messed with the wrong one. So you don't want that to happen. I just want to remind you that with this procedure, there are a lot of potentials for droplet contamination. So you want to always make sure that you have on, if you wear prescription glasses, that you're wearing a pair of goggles. Also, it's a nice idea to have on a mask with face shield. I won't be putting that on for filming purposes, only because it's going to be hard for you to hear me. And it muffles the sound. But again, you want to do that as a self-protection mechanism. Okay. All right. And what I like to do is, personally, I always like to open up my sterile kits first. I'm going to undo my water. I'm using a 0.9 sodium chloride or a normal saline solution, and then most of the time they want you to use hydrogen peroxide. Again, this will help break up any kind of the mucus secretions that are on the cannulas and make it easier for you to clean. You're going to use a half and half hydrogen peroxide, and also then you want your normal saline as your suction irrigation, and then also as your cleaning water for your trach care. So we're going to use these several times. Make sure your caps are set down on the table. So again, you're not contaminating the inside of your cap. Okay. I'm going to open up my trach kit. I'm going to pull that back and get this out of the way. And again, I've got my patient prepared. I have this down. I've explained the procedure. I'm going to, usually these will come on top. So I'm going to place my drape on the patient and put it up here. That gives me a surface to work on. Any more trach care is considered more of a clean procedure than a sterile procedure. I learned sterile procedure, it's just as easy to be sterile about stuff. The idea of this procedure is not to bring new bacteria to your patient. They're already going to be compromised with their airway because they're not using their nose or mouth as a filtering system. And so they're directly taking air into the lower airway when they have a trach. So I want to do everything I can to assure that I don't provide infection to the patient. When I touch the patient or I have any kind of bacterial contamination, it's already going to be his germs. So again, while it's not technically sterile, I'm going to try to keep it as a clean, and when I can, I'm implementing sterile technique. It's just as easy as it is to do it clean. Now, locally, some of the facilities, the respiratory therapists are going to be responsible for trach care, but if you're out in homes, this is your job. You're going to be responsible for having to help maintain these. You're going to do this on a PRN basis and or a scheduled basis, and again, that'll depend upon the needs of the patient and the facility that you're at. So I have my, I'm going to open up I have actually two pairs of gloves here. With the suction catheter comes a pair of gloves, and inside the trach kit. Sometimes the trach kits also will have the suction catheter. We don't have that luxury, so if I know that the patient has to be suctioned, I'm going to open up both my trach kit and my suction. I want to save the cleaning part to after I've known that I've established a good airway. So we're going to suction the patient before we do that. I've washed my hands. I've gotten a pair of regular non-sterile gloves, and I'll do that to remove. Now, when you do trach care, you don't always have to do suctioning. Some patients, if they are stable, they've had a trach a long time, they just need the cleaning. Other patients are going to also need suctioned, and again, your patient dictates what you do. So I've opened up my kit, I've put on the sterile drape. I want to be able to get to this stuff to do this. However, I also want to get those old bandages off. So what I'm going to do is I'm going to put on just a pair of clean gloves. Explain to my patient what I'm doing. Again, assess the need for it. I'm going to pull this off. If this patient needs oxygen, while I'm doing this, I can have someone assist me by holding the oxygen on so that the patient is getting the oxygen during the procedure. It doesn't do you good to put the oxygen up by their nose because, again, they're breathing through this hole. So remember that the oxygen has to come through the trach. Okay, so at this point, what I want to do is I'm going to get rid of the drainage dressing that is around that. These are usually pretty messy with blood and bacterial discharge, serosanguinous discharge. If this is a new trach, we're going to throw that away. Okay. At this point, there's two ways we can go about this. If your patient has a lot of thick, hard secretions on this inner cannula may need to soak for a little while you do your care. So I'm going to, again, decide which hand I want to be the cleanest, which one is going to be dirty. And this is going to remove the trach. I goofed up. Thank you. Well, could roll it. Can you back it up?
Marlene was just pausing it, and then she'll fix it on her computer.
So I now have on my clean gloves. I've removed my dressing. Now I need to prepare my sterile field. So I am going to remove those gloves, throw them in the trash can. I need to, again, clean my hands. So we can use sanitizer at this point. Go to the sink and wash our hands. Make sure they're good and dry before you do. At this point, we're going to need our sterile gloves again, and we're going to set up our solutions. And again, I decide which hand's going to be my sterile hand and which one is going to be my clean hand. So again, I use my dominant hand as my sterile. And then I'm going to put this glove on. And again, it's just as easy. Get in the habit of doing it as a sterile procedure. And I always love it when things are packed backwards. And I contaminated. So let's start over. So I'm going to open up my suction catheter kit. This is going to be peeled back. Give it a little pull so that your paper doesn't snap back. Reach inside, pull your gloves off. And I'm going to open up my gloves. Give it a little snap, and that should hold the gloves open. Now inside your glove kit, you're going to have a suction catheter. You're also going to have a little bowl for your saline irrigation or your rinses. So I, at this point, am going to make one hand sterile, and I'm going to put that sterile glove on. And I'm going to keep my non-dominant hand. So once I've decided on which hand is sterile, which for me I prefer to keep my right hand since it's my dominant, I'll make a fist so I don't accidentally grab stuff. Now there's two ways we can do this. We can do the suction catheter procedure, which I think is how I'll demonstrate this, or I can set up both fields and then go from one to the other, but I'll do separate because as students that's usually the easier way for you to learn. So I'm going to go through the suction procedure now. I'm going to take this suction catheter and lay it here while I get my little irrigation bowl. Now I've taken, both are sterile, and because this kit's been used, this is not working as easy as it should, of course. Now, I'm now going to pour my saline into my package. And that's going to become my irrigation. At this point, I want to turn on my machine. And it is helpful if your machine's on the same side of the bed, but you may not have that luxury, and if that's the case, then turn on your equipment before you start this procedure. Now, when I pull the catheter out of the kit, they usually have this sitting so that the part that's going to go into the suction hose is sticking out. And I work that up so that it's sticking out, and then I bring the rest of the catheter out and make sure that this catheter tip is protected in my hand, because that's really the part that's going into the patient, and I want that to be kept sterile. I'm now going to throw this away because, again, it's trash and I don't need that. Put it in my trash can, and I shouldn't have gone below my waist, but we put it in the trash can. And at this point, this is my sterile hand, this is my non-sterile hand. And I'm going to, with my non-sterile hand, pick up my hose. I'm going to turn on my machine again. I'm going to connect these. And at this point, then I want to make sure that I am going to suck up fluid. I am no longer considering my glove holder a sterile field. If you're going to do that, you can put your bowl onto the sterile field and not take it off, but that's a little confusing. So until you're a little bit more. So I'm going to reach over and suck up a little water. And it's going up the tubing, so I know my suction is working. And again, while I talk to the patient, I'm going to protect the end of that catheter with my hand, the part that's going to go into the patient. I'm going to, again, in the meantime, while I'm setting this up, the patient's hyperoxygenating. I'm going to take this away. I may need to add a little saline packet, so I want to do that just a little ahead. They come as a little package with 1 to 3 cc's of saline in it. You can drop that in to help thin out the secretions. Expect your patient to cough, so you never want to just look down into the trach or you're going to get a face full. So you want to always kind of stand off to the side from the patient, have good access with their neck. Now your human patient is going to be more pliable and softer. You can get their head backwards a little easier. This mannequin's chin tends to get in the way, but we're going to try that. So we check this. I'm now going to check the distance that I want to put it in. And again, this one, some catheters are marked off with centimeter markings, so you'll know. You want to try to prevent irritation of the carina. So take your time. If you've suctioned this patient before, you'll know what to have your suction settings at. If they have thicker secretions, it might have to be a little higher, a little lower for the thinner secretions. And again, you're going to have to just gauge that by what's happening with the patient and how frequent you have to suction. We want as least amount of trauma as possible. So we're going to get ready to go down, and I've kind of marked where the length I think that it needs to be. I've pulled off the little mask, and the easiest way to do this is to stretch out your catheter. So I'm going to go in. And if you go far and you hit the carina, your patient's going to cough. This usually, because it does move a little bit in the trachea, it does stimulate a cough, which helps loosen up those secretions, and hopefully we'll get more. So at the point that I'm ready to come out of the patient, I was taught kind of hold your own breath. If you think it's time, don't have a regular breath. If you take a regular breath and you feel like it's time for you to take a breath, it's definitely time for your patient to take a breath also. This makes them feel like they're getting winded or they've had their air sucked out of them. So it can be very uncomfortable, so be aware of that. And watch your O2 sat monitors. So I'm watching that. I know that that's good. And I'm going to go down. And at the point that I put the catheter in and I'm ready to remove the secretions, I'm going to put my thumb there and come back out. And you can do intermittent. If it's really thick secretions, you may find you have to, have a little longer pressure on there. We're going to come back and we're going to irrigate with the sterile water. Now, this water got contaminated with bacteria, but it's bacteria from the patient. I didn't pick it up off of the countertop, the floor, the sinks, the toilets, or anything like that. I'm going to, with my unclean hand or unsterile hand, again, allow him to reoxygenate. And again, you're going to do that monitoring your patients. Some patients will be fine to go in a minute. Others you may find you have to kind of sit here, let them catch up and take 5, 3 minutes, whatever. You're going to judge it by your patient's SAT levels. And again, I've suctioned people where actually going down kind of stirred up some mucus clots, and I needed to get back down quicker than that. So again, you've got to monitor and judge your patient. But general rule of thumb is at least a minute. So for demonstration purposes, I'm going to pretend that that's gone past. And again, tell my patient what I'm doing. I'm going to put the catheter in. You're going to feel pressure and suction. And again, as I hit that, get to the level I want, I'm going to apply the suction. Come out. Again, put back the oxygen on. I only want to make 3 passes with the trach. Again, if kind of understand that usually that'll do it for you, but if their SATs are not coming out, you may have dislodged some mucus clots or something, you may have to do a 4th time, but usually you don't have to. Just kind of, again, judge your patient, make that. Now, I found in my own practice that I've had times, so I open up my sterile gloves. I'm going to put my gloves on using sterile technique. It's just as easy to maintain your gloves as sterile when you're putting them on. If you get in the habit of putting them on that way, you just make it a habit, and it's much easier. Now, I can keep this as a sterile field or get rid of it. And in this case, I think I'll just go ahead and get rid of it. Throw it in the trash can. Inside your trach kits, you're going to have 3 pipe cleaners. You usually have a couple Q-tips of some kind. Some trach kits also come with a little set of tweezers. These that we're demonstrating with don't have those, but you may see a little set of tweezers. And then you have a little tiny bottle brush. I just leave those in my solutions. I get my dressings out, and you're going to find that you have one dressing that has a split in it, and that is called a drain dressing. On the trachs, you'll find that those are kind of look as if they've been sewn, so you have no fraying edges that can get into the airway, whereas on a dressing like they use on a wound, those edges won't necessarily be as neatly finished off as your trach is going to be. I also should have a tie of some type in there, and at this point with my patient, I've moved my ties gowns down. I'm going to put this behind my patient's head. And then I'm going to put those ties up, again, so I don't ever get them confused with the gown tie. I'm now going to pour my solutions, and my preference is that I do my hydrogen peroxide the furthest away from me so that I don't ever accidentally use it and let it get in the patient's airway. So again, my clean hand, I'm going to pour hydrogen peroxide in the back. I'm going to half and half that with the saline, and then I'm going to make basically a rinse bowl with the larger. So again, a couple different ways to do this. If you have a lot of secretions on that cannula that are hard, I will put this in and let it soak longer. If the patient has thin secretions, it's going to be easier to clean up. Then you'll clean it up and put it in right away. But I'm going to pull this out. It's going into my hydrogen peroxide solution. I'm now going to use just the saline to cleanse the area, and I'm going to start right here at the edge of the trach where I took that off, and in a circular motion. If you have a patient with a lot of secretions, understand that you may need to have more supplies, so open those up as part of your sterile field. And I'm going to go around the edges of that face plate again. Q-tips work really nicely at getting up underneath the face plate for your patient. I'll show you a way to fold your gauzes also so that you make a tip that you can do that. We're going to take the gauze, and one of the ways that I like to fold it is kind of get it into threes, and then kind of fix it so it makes a point. You can dip that in your saline. If you have the tweezers, you kind of get it so that it extends. You don't want a lot of water, so make sure that you get that off. And at this point, I'm going to do my basically the wound care, and I'm going to go one swipe with each of my gauzes. You never want to put pressure forward on the face plate. You only want and I was taught pretty much work from the front. Now, in this case, it's kind of a tight little fit on this side. That's when those tweezers come in handy. But your gauzes in real life, when they're wet, they get pretty small, so it's easy to get in behind that face plate. If the face plate itself needs more cleaning, then I need more additional gauze. Usually they give you about 3 cleaning gauzes. Okay? At this point, he's looking pretty good. I've assessed his skin around the stoma, and you will describe that and document it. I now have the hydrogen peroxide, and I'm going to wash and clean the trach. Again, the reason it's nice to have on your goggles and your face mask is because at this point you really do get a lot of spray. And unless you're wearing a pair of glasses, you don't realize how much you're exposed to through this procedure, but it is a significant amount. Okay. At that point, when I have this cleaned up, I'm going to rinse it. And I'm going to, you can also use your pipe cleaners again to help break up mucus. It's kind of up to you. Since I'm not putting this back in there, I'll just go ahead and lay those in peroxide, or you can throw them in the trash can. And again, just kind of make sure this is nicely dried off. Tap it, make sure it's been rinsed well, and you can kind of just do this to get the excess water off. And then you're going to come back to your face plate, work from the front, tell the patient what you're doing. I'm putting your catheter in. Doing okay. And then avoid looking directly into it while you do this. You need to make sure that these are snapped securely in place or tightened the way that you're supposed to. You should always, at the bedside of a trach patient, have an extra trach. You should also keep the obturator present at the bedside. I suggest taping it actually to the bed, because the bed will go with your patient if they go to x-ray surgery or someplace else. So we should always have a backup trach. My understanding now is that some of the trachs come with the inner cannula as a disposable piece, and you won't have to do this procedure. You may just have to make sure that the face plate, the skincare is done, this gets thrown away, and you just put in a new one. But in the home situation, usually they are a reusable supply. The last part of this is we need to get that tie off and change, and this is where it can get really kind of tricky. Once I start and I have made the untied the knots, undone the Velcro, whatever the piece is, we're going to never let go of the faceplate. This again will come in, the tweezers come in really handy for helping. These ties can be really slimy because of the mucus discharge and the secretions from the wounds. Make sure that you don't put your thumb over their airway hole or block that. And again, you want to make sure, maintain security. If you notice, I don't put my fingers behind the trach plate because I would not want to accidentally make that come out.
Where do I always live? Here or there or the classroom? That's not hard to find.
Okay, I'll show two different ways to tie. So there's this one where you come in and
Go on top.
okay. Remove the old tie, and I'm going to, again, I have cut these so that they're at an angle. It makes it much easier to go in. And with a real human being, they actually are easier to get. If you're having difficulty, your tie, the tweezers come in very handy for grabbing the tip of that and helping. You do want to be careful if you're using a tweezer that you don't get that near the patient's eye in any way. I now want to make my square knot. So that's a right over, you do right over left, left over right. You mean for this to stay in. So we are going to put a pretty secure tie there. If you need to, make a third tie. Make sure that's good and tight and secured. I've had patients that actually will signal that they want it tighter.
She's twisted now that we paid the extra money for the Velcro.
Snug that up. You want to run one finger under and have a 1 finger breadth under there in terms of tightness. That way you know that it's not going to be coughed out. I love my tweezers, so I'm kind of lost without them here. Cinch that up again, and we're going to make a third knot. Again, make sure it's good and tight. Again, check to make sure that you've just got that 1 finger breadth in there. You want to trim these ties so that they're long enough that if you had to get a hold of it and do another tie, you could. But you don't want it long enough that it can possibly go in and get into the airway. So we're going to take the time to just do a little trim with that if you do a double knot like this. Okay. Now I'll demonstrate another one. We'll turn off the camera. I'll fix it. So now we're going to take your gauze that's going to go around the trach on the outside is called a drain dressing. So it has the little split. And at this point, we're going to just tuck it in up underneath those little ties. Just make it look nice and neat. Again, return your oxygen or your humidifier. We would have throughout the procedure been kind of watching SATs, make sure your SAT monitor or alarm's on, so that if your patient were to get into distress, you know, you'll have some warning. We're going to situate him, ask him if he's doing okay. Again, reassess where his pulse rate, his pulse oximeter is. Make sure his call light is in reach, and we're going to, again, put the side rails up. We're going to clean up all of our supplies. Always thank your patient, tell them how good they did. This is not a pleasant thing for them to have done. And so you just want to, again, give them those reassurance and talk to them. If your patient is not a responsive patient, still talk to them. It's important to give that continual reassurance as you're doing what you do.
Thank you.
Washed my hands.